renal system has a function to be able to filter the blood. It also has the ability to reabsorb the nutrients and, of course, secrete the waste. But what makes this part tricky is understanding how all the pressure gradients work and what does that mean to the body. So what I'm going to do is I'm going to go over the GFR. I'm going to talk a little bit about what that contributes in terms of the glomerular hydrostatic pressure. We'll talk about that opposing pressure again, the oncotic osmotic pressure, and we'll talk a little bit about how do we calculate net filtration pressure. So there's going to be a little bit of understanding the arithmetic and the numbers game, because that's how we can see the physiology. And when there is a disruption to these numbers, then you have some kind of problem. So in a nutshell, what happens is we talked about the kidneys, we talked about the nephron, we talked about the different structures of the PCT, loop of Henle, DCT, collecting duct, and nephron. And so the overarching three processes that your kidneys do for us is, number one, filtration. Right? So glomerular filtration is none other than simply pushing the blood into the afferent arteriole and allowing it to pass through the podocytes to filter whatever you don't want out. So this is all based on pressure. So if your blood pressure goes up, if your BP goes up, then theoretically this will also go up because you're getting more blood squeezed into your kidneys. The second process is called tubular reabsorption, right? So this is also important because the more blood, sorry about that. The more blood that your body is able to pass through the nephrons, then theoretically there's a higher chance of reabsorbing whatever you want. And there's a number of ways we talked about how movement occurs. Right? Diffusion is based on a gradient. Osmosis is based on water pulling something. And active transport is based on a protein. So you have different ways of moving solutes back into your body. And I think I had a question, I think it was Adrian asked, or somebody asked about, how does it get reabsorbed to the system? Well, there's also that paratubular capillaries, also known as the vasa recta. That's basically the same thing, just different name as it progresses through the nephron. But these two guys are where you have the blood vessels that help you reuptake whatever you need. So there's a number of ways to get things back in. Then the final process is if you have something you don't want, then you go through tubular secretion. This is going to be at the end stages shown here in this picture with the yellow arrows, where whatever you don't want, you have the opportunity to push out from the blood vessels back into this nephron. And whatever is in this tube here is going to become urine. It goes down to your bladder. Okay, so that's your theme when you look at what the nephrons do, what the kidneys really do for the body. So what makes this part interesting, is when you look at how the pressure gradients work. Okay, so I'm going to change my slides a little bit. Let's go down a little bit here. So what we have is we have some substances that are freely filtered, meaning, these are small things that your body can easily just pass through the membranes of the podocytes and they get into your urine. So therefore, when you eat a lot of sugar, or if you eat a lot of caffeine, or if you eat a lot of carbs, you will see traces of that in your urine. However, there's also some that are non-filtered, right? Larger proteins or red blood cells, those things cannot pass through that podocyte filtration membrane. So if you do see any of these non-filtered chemicals, then that indicates there's infection or damage. And then one more feature that the membrane provides for you is also has a negative charge. So that negative charge repels certain ions as well. So again, there are moments where you have a series of barriers that can block stuff from getting through. So when you think about the pressure and the driving force of this, we talked about this back in the blood vessel. We talked about this during the air pressure in the respiratory system, but this is still the same recurring theme again. We have what they call the net filtration pressure, which is going to be two forces, and you got to take account both ends. The first force that we have is called the hydrostatic pressure of the glomerulus. This is how much pressure that is being forced and pushed by the blood into the capillaries so that you're forcing the stuff to be filtered. Then on the other side, we have that tug-of-war effect. Remember the oncotic or the osmotic pressure? This is the opposite, where you're trying to retain the solids back in because of fluid. So you have that opposing pressure, which is osmotic, oncotic blood pressure. And of course, there's also that slight bit of fluid pressure in that capillary space between the two membranes. And I'll show you a picture that makes sense. So when you take all of them together and make the difference, you then get net filtration pressure, NFP. This is the true value of whether or not you're pushing fluid in to the lumen or if you're not able to get things across. So we got to have some numbers in there, and you'll see this in a second. But the first value of this story begins with what we call HP sub G. So HP just stands for hydrostatic pressure, like we've seen a couple of times now. The lowercase subscript g represents the glomerulus. So it's the glomerulus hydrostatic pressure. The pressure in the glomerulus is directly affected based on the blood pressure of the cardiovascular system. And what you will see here is that when you have a larger diameter of the afferent arteriole, you will allow more of it to go in. Right? It makes sense because you are able to push more blood into the filter system if you have a bigger afferent arteriole. So this dilation helps you get more things across. If you also constrict the afferent arteriole, you will also increase GFR because you're trapping more of the blood inside that glomerulus head. So be aware. I think I asked you guys this question on Monday. What would you do, right? If you have a high blood pressure, how would your afferent and the efferent arteriole accommodate to that pressure? How would you adjust this vessel so that you can maintain a higher blood pressure? So over here, the opposing forces are going to be then OP sub G. So OP stands for osmotic pressure or osmotic oncotic pressure, and G stands for glomerulus. Okay, this is the force that basically fights against HPG. So these two are trying to tug a war with each other, see which one is greater, and that will determine the way the fluid is going. All right, so it's a tug of war effect. And this is opposing filtration, and this is the one that draws it back into the glomerulus. And we also have that third slight pressure called the capsular hydrostatic pressure, a small little bit, not super significant, but it's still present, and this also impedes the additional fluid pushing in. So this is also on the same side as the osmotic pressure. So just remember these two are on the same team, and then the one I showed you in the previous slide, this is on a team by itself. So when you do the math together, you can put the equation and you can get this kind of expression, HP sub G minus OP sub G plus HP sub C. So these two are together. You subtract the number and you get NOP. So the significance of this is, if you remember, we said this before, where when you have a positive value as a result of pressure differences in physiology, you tend to get filtration. This favors the pushing across the membrane. So let's just put some numbers in there, and these numbers are relevant to a healthy nephron. So you have 60 millimeters of mercury of pressure, of hydrostatic pressure from the blood pressure that's standard, 120 over 80. By the time it gets to your kidneys, it's gone down to about half the pressure. Then 32 millimeters of mercury plus 18, you have roughly 50. So it's a big number minus a small number. You still get a positive value. The problem with this is if you have a patient that comes in and they have a gigantic osmotic pressure, let's say, there are so many proteins being trapped in the system, or something is absurdly wrong, the blood pressure is super low, where it's a small number minus a big number, let's say this is a big number, and you get a negative value, then that means the kidneys are not working anymore. Does it make sense? They're not able to filter. That means your filtration system is toast. You can't filter the waste. And that's how, when you look at kidney damage or acute kidney functions or chronic kidney disorders, when you start losing kidney function, that's when these numbers go completely the opposite way. Okay, that means you don't have the filtration ability. So altogether, when you think about what makes this important, is then there is this value called GFR. GFR stands for glomerular filtration rate. And this is the expression of truly how much blood are you filtering in 1 minute, right? You can measure this. And there's different tests. You could use inulin test, creatinine test. You put it in your system and see how much of it when you put it in, and how much and how long it takes to get it out, right? So you can track roughly how well our kidneys are working. And so there are many things that can affect GFR, right? One of the big ones that I pointed out is, of course, the afferent and the efferent arteriole. Another one that can also affect the GFR is simply your genetics, how much surface area and how many nephrons that are active, or how big your kidneys are. Theoretically, a big kidney would work better, right? So I know there's a true story. There was a patient, one of the students that had a kidney transplant, and she was a female, really petite female, and she got a transplant from a male, or her husband. And her husband was like a big guy, 6 foot something, and so she had this gigantic kidney implanted into her, where she was able to filter, her entirety of the blood so much faster because she had a bigger kidney, right? So it's interesting to know that the size plays a role, surface area plays a role, and then of course there are also some intrinsic and extrinsic controls. So these are hormonal based, right? So the renin, aldosterone system, all those can affect it as well. So what I want to go over is there are 2 very important intrinsic regulations that your kidney does to maintain blood pressure and GFR, to keep it healthy, right? Because you don't want to have too much blood hitting your kidneys all the time. That's why high blood pressure is so bad, is that you're damaging your kidneys without you knowing it. So the 2 natural ways your body can use to control this is, number 1, we have a myogenic response, And then the second one is we also have a tubular glomerular feedback mechanism. And I might not be able to get to all of it today. I might maybe polish this a little bit more on Friday, but I do go over it in my video. All right. So the first one, the myogenic response, is answering the question I asked you guys on Monday. So what happens when your blood pressure is too high or too low? So when your body has a drop in blood pressure, right, because there's less blood going around your heart, your body, and your heart isn't squeezing as much fluid, there's going to be less stretching of the arterioles and the smooth muscle. So what's going to happen is then your body's going to think, well, hey, we don't have a lot of blood. Then we can open up the door a little bit to get whatever blood is coming in into the kidneys to filter. So your smooth muscles tend to relax and dilate, so more blood is allowed to go into the glomerulus because you're not allowing the pressure to damage the system. So you compensate by maintaining healthy GFR. And GFR is about 125 mLs per minute, right? So you have a certain number that you're aiming for. And then on the other side, if your blood pressure was really high, that was a question I asked you guys on Monday. If it's really, really high, then that means this thing will then constrict and less blood will go in. So the reason I have the slide set up like this is if I tell you one half of the story, I hope you can infer the other half. If I decrease blood pressure, smooth muscle dilate, more blood. If I increase the blood pressure, then you will constrict, right? And then you would have less blood go in the glomeruli. So it's literally, you should know the whole story just by knowing half the story, right? So study smarter, not longer. So one way that our kidneys can regulate your GFR, right, is through the myogenic response. And that's just what I went over right now. So you can constrict or dilate the afferent arterioles or the efferent arterioles. So now the second part of the story is going to be what they call the tubular glomerular feedback mechanism, which is the second way you can control the system. So it helps you support the myogenic response, but this also can do something else as well. So what happens here is that the amount of sodium, the amount of fluid or water in the body could be detected by a set of specialized cells called the maculodentate cells. And these are the cells, if you recall, that are the specialized sensors that are found at the ends of the PCT, and they kind of touch the entry point of the afferent arteriole. They're physically touching how much blood and fluid is going through. And so when you detect this kind of boosting or increasing in the sodium amount, you can cause the vasoconstriction to squeeze down even further. So you can change the way that you are allowing more blood in or out. So it's a sensor. And this is the same set of systems, the JG cells, the juxtaglomerular cells that we talked about, that release renin. Remember that? So we talked about renin a while ago, when it becomes, to the angiotensinogen, angiotensin 1, angiotensin 2, and then makes aldosterone, right? So that same pathway is how this comes in to regulate how much water your body can take in. So it's a very dynamic process because you don't want to have too much water in the body, right? You're chugging a gallon of water, and your body, your kidneys need to know, well, if there's that much blood that much fluid in my blood, I can't allow so much fluid and that pressure hitting my tiny little kidneys. But at the same time, if you're dehydrated and your body's trying to move some fluid into the kidneys, then it can also adjust that as well. So it's changing relatively constantly, and it depends on, that's why ideally you should stay hydrated. It's always good to maintain a steady state of how much water you're taking in a day. You don't want to chug a gallon one day and then dehydrate yourself for a few days. You're shocking your body too much that way. So let's talk a little bit about numbers. So how does this relate clinically? Well, this is the cool part. So there are some limitations to GFR. In a healthy individual, and this is where the blood pressure makes a lot of sense, the autoregulation in the kidney system is able to maintain and play around with about 80 to 180 millimeters of mercury of pressure. So this has obviously been experiments that they've conducted on patients to see, can your kidneys compensate to what degree, right? How much can your kidneys really take? And it's a pretty big range, right? Because 120 over 80 is your standard, golden, blood pressure, systolic, diastolic number. But when your blood pressure decreases below 80 mils of mercury, so if you go dehydrated and you lose so much blood and you go below this number, your arterioles have dilated to the max it could physically go. Okay, so there's not much more you can do. And then when you go to anything over 180, that's why this is definitely kind of redlining, that kind of high blood pressure emergency or crisis point. This is where you have the maximal constriction your arterioles can take. So, they've done experiments to be able to come down to the point where they know exactly these are the top end of the human body limit, and this is the bottom end of the human body limit, which is pretty cool to know. So that's why when you think about this, 120 over 80 is a pretty conservative, pretty safe range to have fluctuation. right? So that's why you don't want to strain those tubules. And then obviously when you're in a constant state, imagine you have high blood pressure, right? You're over here. That means your blood vessels have constricted like crazy, and all the other fluid in the blood that's trapped in your blood cardiovascular system is damaging other smaller vessels, like the ones in your eyeballs, the ones inside your lungs. That's why you have retinopathy and eye damage, because all that fluid is hitting the vessels and pinching down on nerves. So I hope that makes it kind of interesting to know that there is a number to this story. And this is a visual to kind of tie this all together. So going back to Katrina's question, you're like, what does it look like, and where is this going? So the afferent arteriole comes in with the blood entering in. You have the JG cells, macular densin cells right here. These are sensors. The afferent arteriole leads out, and you can see HP sub G is about 60 for a relatively healthy blood pressure. And then you have both osmotic oncotic pressure reversing it, and the hydrostatic pressure of the capsular head. You have two of these on the same side, on the same team, which should be in a healthy person lower than the HP sub G. As long as you get a positive value, it could be 9, it could be 10, it could be 9.5, something that is close to 10, you are going to have a healthy filtration where blood is pushed into the nephron and still blood comes back in. In a patient where you have kidney failure, AKI, acute kidney injury, or some kind of kidney disorder, then this number oftentimes will be flip-flopped. You'll have a situation where this could be a positive value, where fluid is backtracking in and you're not able to filter at all. So you're trapping this and damaging these sensors and these vessels. Right? And that's why it's not one day that'll kill you, right? If you chug a gallon of water one day, if you decide to, I don't know, chug alcohol for one day, it's not going to kill you. But if you're doing this day in, day out, and you have gigantic pressure that your body can't overcompensate, then you're going to have a permanent damage. So I hope that makes a little bit of sense there to put it all together. Numbers are, obviously I don't try to make numbers required for you to know, but it is really good to know what are some of the ranges, especially when you get a high blood pressure. What's happening. Well, if you get a patient that has a hypertensive crisis, right, 180 and plus, their arterioles have literally constricted to the max that they can. So there's nothing else they can do to compensate at that point. So then you got to have drugs, or you got to have some kind of procedure to help with the process. So this is a pretty cool picture as well, clinically, kind of relevant. So you can see right here that you have the blood pressure graph on the x-axis, and this is showing you as the true arterial pressure, which is again MAP. So this is the mean arterial pressure for the two places of leaving the heart and coming in. And you can see that in a healthy person, right, your normal urine production is maintained for a really good range. Your kidneys do a really good job of holding you steady state for this entire 180 millimeters of mercury. But anything below 80, you have this gigantic drop off, and anything over that, you have excessive urine production. So that's why, as long as you're within this range, you're relatively healthy. But when you are hypertensive or hypotensive, that's when there's problems.